So this is the case scenario that has been given. We have a patient, geriatric patient again, 75 years old. He has comorbidities, diabetes, and hypertension. So first analyze the case. 75 years old patient. So he's a geriatric group patient. He has a comorbidity of hypertension 20 years, diabetes 15 years, and BHP with voiding difficulty posted for TURP. So these are all the problems in this case. The next thing is information regarding primary problem of voiding. For that, there is a mnemonic you can remember is HI. I actually has to be 2I. It's fun. What is can you just expand on that mnemonic or the acronym that I have given? What is H standing for?
Hesitancy.
This is the difficulty in urination. One of the questions that have to be asked. Hesitancy, very good. I.
Incomplete sense of voiding.
Incomplete voiding, very good. And also intermittent stopping. He may not have a continuous stream, he may have a intermittent stopping. And S for
Stream.
Thin stream. And F for
Frequency.
U for
Urgency.
N for
Nocturnal.
nocturia. Okay, so these are all the things that you have to ask for. And this has been the symptoms that have been described by the American Urological Association. Okay, these 7 symptoms are the classical presentations of difficulty in voiding in TURP patients. Okay, and any other associated surgical conditions like hernia and hemorrhoid, because these patients usually strain a lot to pass, especially when they have a very thin stream. They always increase the abdominal pressure by straining. So then they develop a hemorrhoids or a hernia. So as for that, any medical treatment tried or being continued, that is another history that we have to ask. And whether the surgeon has told him about the gland size and the lobes involved. Normally during TURP resection, which lobe do they resect?
Median lobe.
Median and only median? Median will be projecting from the middle. But which one can compress the urethra? Lateral rope. So it is median and lateral rope which are resected. And the hypertension, whether it is controlled, uncontrolled, what is the drug treatment, and what are the drug target organ dysfunctions, that is another thing that we have to ask. Diabetes, controlled, uncontrolled, and what is the drug therapy, and whether you have to stop the drug therapy. Usually, supposing patient is on OHA, will you ask them to stop before TURP, or will you ask them to continue with the drug and change it to insulin?
Stop on the day of surgery, sir.
Only on the day of surgery you have to stop. You need not switch over to insulin. That is the basic thing that you have to remember. Why?
Unaware of the patient is more prone for hypoglycemia, sir. So insulin will cause more hypoglycemia.
Is it the reason for not switching over to insulin?
Hypokalemia, electrolyte dysfunction.
Will you allow oral after TURP surgery, or starving for 24 hours or 48 hours?
Hello, oral, sir.
Eh?
Hello, oral, sir.
You will resume oral intake as soon as possible, isn't it? There is no need for prolonged starvation post-operatively.
Yes, sir.
Isn't it? So
Yes,
that is
sir.
the reason why you don't have to switch over to insulin. Only in cases where oral intake is not permitted, like abdominal surgery, where you wait till all the bowel movements are returned, where patient is not given any oral food intake, then you have to go for insulin therapy. Otherwise, when you can resume oral as early as possible, you can always continue with the medication and restart the medication after stopping it just before surgery. Okay, that is the answer that you have to remember. and any musculoskeletal issues with the joint mobility, especially after this case scenario of hemiplegia. What can happen to the plegic leg? Even though he may have a normal gait and movement, what is the one problem that can happen in the hemiplegic recovered leg?
Rigid movement.
Some amount of rigidity may be there. So putting the patient in lithotomy may be quite troublesome. Okay. So that is, and another question they may ask you is it safe to give a spinal after a hemiplegia, which is a neurological disorder?
Yes, sir.
Yes. Why? How do you explain that it is safe?
So,
Huh?
If it is recovered and there is no muscle,
Okay, it's not recovered. He is the hemiplegic state, and he requires any bladder intervention. Will you give a spinal in a hemiplegic patient or not?
if it is not recovered, we'll go for
no,
CS.
sir, we should not give.
Not at all. Not. It is no contraindication at all, unless you have a spinal peripheral nerve disorder. A central nervous system disorder like a stroke is not a contraindication for spinal anesthesia. Even in paraplegia, where there is a bed sore and they want to do a rotation flap, can you give a spinal?
Yes, sir.
A
Sir.
paraplegic patient who has no sensation below the umbilicus, he develops a bed sore in the trochanteric region. They want to exercise that sore and do a rotation flap. Is it safe to administer a spinal for him or not?
It won't take the bed sores, the infection won't take the.
There is no infection. Wound culture is sterile. And it is in the trochanteric region. You are going to give spinal in the L2, L3 space or L3, L4 space. Trochanteric region is almost at the most bottom portion of the gluteal region. You can give, even in a paraplegic patient, you can administer a spinal anesthesia, especially if they have what is called the hyperreflexic state. Some of the paraplegics develop hyperreflexia on and off, which produces an intense sympathetic stimulation causing high BP, headache, sweating, and all these problems. So, even though they don't have sensation, majority of them can be operated without any anesthesia by just sedation and reassurance. But patients who have this hyperreflexia, they need some type of anesthesia, either GA or regional, to avoid an intraoperative sudden spike in high blood pressure. Okay? So those patients can be safely administered spinal anesthesia also if the bed sore is not close to the site of your needle insertion. Okay? That is the answer that you have to remember. Right. Then renal involvement due to obstruction and back pressure effect. In pre-op investigations, you have to mention that you have to document the pre-op serum sodium level. This is one of the important things in the pre-op investigation, because why this pre-op sodium is very important.
Turp can lead to hyponatremia, sir.
Then only you can identify Turp syndrome. When you take a blood sample and send it first before you start treating Turp syndrome, you will find there will be a sharp drop in the sodium level. Okay, it is mainly the hyponatremia which causes all the CNS effects in Turp syndrome. So unless you know the baseline value of serum sodium, you will not know whether patient was already in a hyponatremic state or not. That cannot be established, especially if some other complication happens and you have to defend yourself in the court of law. It is always mandatory that you should have documented the baseline sodium value case sheet, and then if the complication happens, you have to record the sodium value later on also. Then risk stratification based on the age of the patient and his physiology and the control of the comorbidities. and pre-op optimization of BP, glycemic control, drug adjustments. These are the things that you have to remember. Pre-op instructions, because these are mainly elective surgeries, NPO, drug adjustment, anti-anxiety, anti-aspiration medication, and blood sugar management. Intraoperatively, preferred technique is the single shot subarachnoid block. And the advantages of that are it is technically easy. And there may be mild hypotension, which helps the surgeon to have a clear vision, because when he resects the gland, it will not bleed that much if there is a mild drop in blood pressure. And you can early diagnose the PRP syndrome is possible. Disadvantages are sometimes in elderly patients, the spinal may cause very severe hypotension. Contrary to the normal, it may cause severe hypotension. And some patients will start shivering during the surgery because of the reasons she mentioned. And sometimes in the initial stages, there will be a penile erection, which will prevent instrumentation. Proper insertion of the resectoscope will be difficult. Intraoperative fluid management, you have to assess the fluid loss, blood loss, assessment of fluid absorption, and you must learn all about the irrigation fluids. And sometimes they may twist the question by saying that patient having a pacemaker may come for PRP. I have done about 3-4 cases in my career. So spinal is not contraindicated, but you must take care that the pacemaker machine is not affected by keeping the all the electrical interference far away from the patient. And all about PRP syndrome, the clinical features, complication, diagnosis, and confirmation treatment. And if GA is required due to patient refusal of spinal coagulopathy or infection, the common question they ask you is, how will you identify PRP syndrome? Here again the answer is the rise in BP. Okay, because the pain is not that much in these cases. Fluid absorption only causes the increase in the blood pressure. And post-op management of pain, shivering, bleeding, and clot retention and exploration are all the things that we have to remember in these cases. Quickly going through the anatomy, the prostate gland is surrounding the urethra, situated in front of the rectum. That is why a rectal examination is a must to simply find out the size and the consistency of the gland. And it is all not necessary. So you have this is the number of lobes the prostate gland has. And you can see this is the urethra. This is the proximal urethra. And the median lobe is the one which is there here. And the two lateral lobes are there. So commonly the median lobe will enlarge. And that will be the cause for the bladder neck level obstruction. So they sometimes do a small resection of this one, which is called the BNI, bladder neck incision or resection. But when the lateral lobes are also enlarged, they may also require resection. And anterior and posterior lobes are very, very rarely. If they are also hugely enlarged, they may require total enucleation and not the just pure failure. So the locations and the nature of cells that they are showing is the anterior lobe. You have what is called the transition zone, median zone, and posterior zone. So these are the things that you have to remember. And where exactly the BHP occurs is the question that may sometimes be asked. It is the transition zone is the most common for the prostatic cancer, whereas the central zone, I think that is the one which is more commonly benign prostatic occurs in the transition zone. First, sorry, this transition zone is a common area, but peripheral zone is the common area for prostatic cancer. So transition area, this is all the anterior fibromuscular zone, transition zone, the central zone and peripheral zone. So these are the zones which are responsible. Blood supply, of course, from internal iliac artery, prostatic artery, which is a branch of internal iliac, and then that divides into to supply that. And the venous channels are the plexus which are draining that, and they are the ones which are open. So prostate is surrounded by a true capsule, and there is a false capsule outside, and in between that only you have the venous plexuses. So what they do is they are resecting the gland, they open up the channels. Okay, so they remove that. The true capsule only will be removed. They remove the false capsule, then fluid will start going out into a extra protected spaces. And symptoms, of course, we have seen that the stream is thin, frequency, urgency, nocturia, fear of evaluation, all the things we have seen already. And what are all the investigations pertaining to prostate that is done by urologist? Basic thing is rectal examination and transrectal ultrasound, and then use the abdomen for KUB and prostate, including pre and post void urine. What is the minimum post void urine which is considered as an obstruction?
66.
After asking the patient to void, how many ml of urine retention in the bladder indicates that there is an obstruction? 60 ml. Okay,
60
so
ml.
it is more than 60 ml or more is considered as an index. Up to 60 ml you can ignore it, but well above 60 ml it is definitely indicative of an obstruction, and you must always do a prostate specific antigen values
PSC.
to rule out any malignancy. In transrectal biopsy if needed. So when will a transrectal biopsy be indicated? If the PSA
More
values
than
are
10.
high, or when the surgeon finds the gland is very hard and irregular instead of the firm consistency. If you find it rocky hard, then you may ask for a biopsy also. And renal function, urine and culture, because you don't want any urosepsis occurring in the patient. Pre-surgical tests, I have again identified and highlighted sodium levels. So please remember that you must ask for serum electrolytes and note the sodium value. Medical management, of course, we have already discussed. Alpha receptors, non-selective. Phenoxybenzamin is a non-selective alpha receptor. Which other condition you will use this drug?
Pheochromocytoma.
Pheochromocytoma, fantastic, very good. Short-acting drugs like trazodone, alfuran, and long-acting drugs, terazodone, doxazodone. Partial subtypes are tamsulosin and silodosin. And tadalafil is DHP with erectile dysfunction. 5-alpha reductase inhibitors. They block the testosterone conversion into dihydrotestosterone in the prostate. They not only inhibit the growth but also help in the apoptosis and involution. Drugs example are finasteride and dutasteride. And usually the combination is being given, alpha blocker and 5-alpha reductase inhibitor combinations are available. So other uses and side effects are trazodone given for hypertension also, phenoxybenzamin and used in pheochromocytoma. Tamsulosin is the one which can cause floppy iris syndrome, and that may be troublesome during cataract surgery. Okay. Indications for surgery in a BHP: recurrent UTI, acute urinary retention, recurrent hematuria, bladder stones, and renal damage because of the obstructive uropathy. Relative indications are morphological changes in the bladder or upper tract, constant and increasing post-void urine, more than 100 ml, recurrent urinary infection secondary to bladder outlet obstruction, and patients' willingness to get surgery because they have to take the medicine every day. Some patients, they want to get rid of that problem once for all, so they want to get operated. Contraindications classified into absolute and relative. When there is an active urinary infection, you should not operate. That may, as Priya said, it may get into the circulation and cause what is called the urosepsis can happen. And coagulatory problem also is a contraindication. Relative, large bladder stone, anesthetic considerations, and acute renal insufficiency secondary to bladder obstruction. Free of consideration, you must stop the antiplatelet agents, get informed consent. Usually, in our setups, we save the genital area, but the Western people, because it is just going through the area, I mean the urethra, they don't save the external genital areas. Antibiotic cover is a must. She rightly said gentamicin is the drug of choice. And this is the common operative room picture for those who have not had a chance to witness a PRP syndrome. Here they are using the monitor to see the thing. Earlier, the surgeon used to bend down and visualize the prostate through the resectoscope itself, through the eyepiece. Nowadays, because that causes a lot of neck pain and strain, nowadays we have these monitors which are attached, cameras which are attached to that. So looking at that, the surgeon will be able to do it comfortably without straining his neck. And these are all some of the adaptations to collect the fluid that is being expelled every time, or spilling out from the while taking out the resectoscope. The irrigating fluid will soil the whole area. So some people have designed this funnel-like thing attached to the table, which can collect and directly take it to the sterilized containers, which can take that. And this is how the positioning is done. So we can do this position or little. So these are various right and wrong methods of doing the lithotomy position, and that's very important to prevent any injury to the sciatic nerve and other nervous injuries. So this is how the steps in the thing. And this is what is the name of this instrument? Which is used to remove the bits of prostate that have been resected and dropped into the bladder.
Resectoscope.
Elens.
Huh?
Evacuate. Elens evacuate.
Helix evacuator. Okay, the helix evacuator. So the types of irrigating fluid, this is a common question in the exam. So what is the characteristics, that all you have to know. Earlier, they used to use only distilled water because this will not allow the electricity or the current to fill. So it used to conduct the electricity very well, and the reception used to be good. Then later on, glycine 1.3%, 1.2, normal saline, and trinyl lactate, all that have been used. And the advantage of the characteristic is it should be as far as possible isoosmolar, so that it will not get absorbed very rapidly. But the glycine that we use is not totally isoosmolar, it is slightly hypoosmolar only. And other things are mannitol, sorbitol, glucose. These are all earlier used, but nowadays not very commonly used. And the complications of irrigating fluids, especially glycine, it is normal plasma glycine level is 13 to 17 milligram. So they may ask you this. So transient blindness is attributed to glycine toxicity. So glycine is a major inhibitory transmitter acting on the spinal cord and brain stem. Glycine also has been implicated in myocardial depression and hemodynamic changes associated with PRP, and it may lead to ammonia toxicity also. Absorption can result in CNS toxicity because of the oxidative biotransformation of glycine to ammonia. most preferred technique is single shot, and the level required up to T11, even though the nerve supply to prostate is mainly from the lower lumbar and sacral, but bladder distension will cause discomfort. So that is the reason why you require a block up to T11. So that is another common catch question they will have. They will ask you what is the nerve supply to prostate, and it is mainly the sacral S2, S3, S4 segment. Then they will ask you why you want a block up to T11. The answer for that is because of the irrigating fluid, there will be stretching of the bladder. So bladder discomfort is avoided only when the block is above the umbilicus. And advantages and disadvantages she mentioned. Contraindications for SAB, all that we have mentioned. Here, complications are PRP syndrome, glycine toxicity, hemolysis, hypothermia, bleeding, perforation, and bacteremia. And what are all the things that happen? Glycine toxicity, all that is, I think, more. This rule of 60 is a common question they may ask you to prevent Turp syndrome. Why this rule of 60 is there to prevent the occurrence of Turp syndrome? Restrict the resection time to 60 minutes, resect less than 60 grams of prostate, and restrict the height of the irrigating fluid column to 60 less than 60 centimeters. If you do that, the chances of Turp syndrome are very much less. And things that happen at various levels of decreasing sodium. At 120, from 135, it comes to 123, patient goes in for confusion, restlessness. ECG will show a white QRS. When it goes to 115, they will have nausea and drowsiness, and the white QRS and ST elevation will happen. When they go for 110, they may throw a fit, they may have ventricular tachycardia or fibrillation. So this is the thing that is also asked at various levels of sodium, what are all the changes that happen in the patient as well as in the EKG. Treatment, immediate starting of surgery, warm normal saline for irrigation, assist ventilation, and send the blood for CBC, electrolytes, and coagulation profile. Lasix 20 milligram, and those on, if the patient is already taking Lasix for some other cardiac ailment or anything, you have to give extra dose of 40 milligram. And they more based on the response obtained from the initial 20 milligram. Then you can start using hypertonic saline. If necessary, measure the central venous pressure, arterial BP, and pulmonary artery catheter if necessary, if hemodynamic instability is there. Also start monitoring potassium. Don't concentrate only on sodium because we are going to give fluids. We have to monitor sodium also because hypokalemia can also occur with diuresis. And reassure about visual changes, and this is the treatment that we have to remember. Glycine toxicity treatment is with arginine and magnesium to have a negative control on NMDA. Vision will return to normal when glycine levels return to normal, and that will happen within 24 hours. Hemolysis is another complication. Bleeding is another complication. So blood loss calculation. This is commonly asked in the exam. How to calculate the total blood loss in PRP syndrome. Any idea, Priya?
So, hemoglobin of the irrigation fluid divided by patient's hemoglobin into total irrigation fluid use, sir.
So, hematocrit of the, not hemoglobin, hematocrit of the irrigating fluid multiplied by the volume of irrigating fluid divided by hematocrit of the patient. Not the hemoglobin value, but the PCV, hematocrit value. Okay, that is what you have to do. And volume of irrigating fluid absorbed can be calculated using the sodium value. Using free of sodium divided by post of sodium multiplied by extracellular fluid volume, and from that you subtract the ECF volume, then you will get the amount of fluid absorbed. The causes of bleeding, circulatory overload, vasodilatation, urokinase are the reasons. Perforation and bacteremia, hypothermia. These are all the complications. What is this I have shown here?
At the end of the procedure, they will put a three-way catheter, Foley's catheter, and pull it towards the thigh,
Yes.
so that that causes compression and causes further decreases the further bleeding, sir.
Very good.
Pressure
That
venous
is called
causes
traction. Okay, traction of the bulb, Foley's bulb. So bulb is inflated with what? The Foley bulb
40
is
ml
inflated.
distilled water, sir.
It is filled with water and then pulled into the bed of the resected area to prevent bleeding. Okay, and this irrigation fluid also has to be calculated for post-operative this thing. And this inflation of the inflated bulb only causes the trigone irritation and cause bladder spasm.
Yes,
And that may also produce restlessness in the patient. And bleeding and clot retention, shivering, fluid overload, and urosepsis. These are all the post-op problems. So that will be the end of this. Okay.